We'd like to introduce Dr. Deeb, who's agreed to speak with us today. He graduated from the medical school at the University of Balmain. He completed his neurology residency at the University of Massachusetts Medical School and movement disorder fellowship at the University of Florida. He is now an assistant professor of neurology at the University of Massachusetts Medical School. His clinical interests include Parkinson's disease, deep brain stimulation, and Tourette syndrome. His research interests include using technology and health delivery and access. So thanks so much again for joining us today, and I'll pass it over to you.
Thank you for having me. And this is a topic I enjoy speaking about because it's close to my heart. And since I was a teenager, I like gadgets and tools, and that's nice to be capable of combining that with medicine. And it is something that's really significantly, let's say, exploding in its use and developments recently. I'm assuming you can see my shared slides right now.
Yeah.
Thank you. There's a lot to talk about, and there's so many things we can talk about. So I selected a few things that I thought are interesting to people, maybe interesting to people, and then be happy to have questions at the end if you have any questions or certain concerns about this. So I have no direct disclosures about the stuff I'm speaking about today. And today we're going to go through these three different components. We're going to initially start to discuss about how we usually approach our care for people with Parkinson's, and then how we started using telemedicine and the advantages and disadvantages of its use. We're going then to discuss the use of multiple types of sensors, including wearable sensors, and then finish on the role of virtual reality, focusing mainly in the realm of telerehab, although it has multiple other applications too. I'm going to start initially by asking for your feedback. We're going to start with a poll that's going to appear soon on your screen. And I want you to select all the terms that you are familiar with, that you might have heard or not about. So just choose any of the answers you can have that you are familiar with in that list. Yeah, I just discovered that. You're correct, John. Okay.
Great. So we've heard from most people. Should I end the poll?
Yeah, we can end the poll.
Great. All right. I can share these results.
Yeah, because everybody could choose only one answer. I think everybody chose the most common, like their most important answer to them. Some people might have known more than one term, but we can see here Parkinson's diary is not something that people chose. Freezing of gait is not an uncommon thing people have chosen. One person have chosen UPDRS, and we'll speak about that. And then also many people also have used and heard of wearable sensors. Okay. So as you all know, Parkinson's disease is a complex disorder, and it requires frequent monitoring and frequent assessments for the different components that happen during the disease evolution, and then also to help manage the symptoms. So that would be motor symptoms, and that would be like bradykinesia, which is mainly the slowness of movements. That would be rigidity or stiffness of movements. That would be tremor, as well as freezing of gait and multiple other motor symptoms. There are also a combination of non-motor symptoms, and the list here is is quite long, but we can think of cognitive changes like memory changes or attention problems. We can think of sleep problems. We can think of mood problems, as well as gastrointestinal problems, among others. So all of these types of symptoms are symptoms that whenever we go to the doctor's office with Parkinson's symptoms, these are some of the things we track. And then we try to assess in that 30 minutes or 20 minutes we get with the doctor. And then in addition to this, as the disease progresses, especially after that 5-year mark, many individuals start developing fluctuations. So where the effects of the medications they are no more steady and they keep going up and down in their intensity. People can develop dyskinesias, and then also there would be consideration for advanced therapies such as the brain stimulation, the levodopa carbidopa intestinal gel, as well as the subcutaneous apomorphine infusion, which in the United States we might hear about from the FDA next month, if that's going to be approved or not. But these are different things we would be discussing. As you can see, there's a lot of stuff going on that would be discussed, and many of these might not be apparent at the time of the visit. And then also, as an individual advances into what we consider to be advanced PD, there will be more symptoms to discuss, more complications of treatment that we have to discuss. And this is one definition of advanced PD called the 5-to-1 criteria, which is if a person is taking more than 5 oral levodopa doses a day, having more than 2 hours of off symptoms per day, and more than 1 hour of troublesome dyskinesia per day, they meet one of the criteria for advanced PD. There are many criteria for advanced PD, but individuals in this group would require more monitoring or more follow-up. We're going to have another poll this time, and then this way I want you to select the ways you or your healthcare professional track your symptoms, and you can select multiple choices right now. So whether you discuss it during the visits, is it simply through the exam? Do you fill Parkinson's diary? Do you routinely use or sometimes use wearable sensors, or you're not sure about how you and your doctor track your symptoms? And we got a good number of answers here. I'm going to end the poll in a second. Okay. And then most people mainly discuss it, and and as well as the physical exam, only one person mentioned using wearable sensors. So hopefully after this discussion, more of you would be using wearable sensors, or think that it is helpful to use wearable sensors in the care for Parkinson's disease. All right, so let's go through how we usually evaluate people with Parkinson's, which most of you have mentioned the usual steps. So you go in, you get checked in, you get your exam and vitals, you get the dreaded questionnaires. Usually, sometimes they can be many pages, even during the visit or before the visit. And then also, we do certain measurements like certain scales, adjust the medications, and discuss a few things. So that's usually how the visits go. We need to see you frequently in order to address all the different symptoms and assess the changes. And that can be a drain on your time. It can be quite costly, and also it can also be very tiring, especially as Parkinson's disease progresses. It can be sometimes tiring to leave at certain times of the day, and then the time of the appointment might not be the most conducive to a visit. So one of the ways that there has been some development to help with this is telemedicine. And as you've all experienced most likely during COVID, telemedicine has become a mainstay of treatment. Before that, it was a bit hard to get telemedicine services for multiple reasons, including lack of payment. But right now, telemedicine is here and it's not going anywhere. It has a lot of advantages for sure. You can have the assessment at home. You don't need to travel. So it's much less costly to travel to the doctor, as well as much less time that you would need to spend waiting for the doctor and then going to the doctor's office to do the assessment. So you get that assessment possibly more frequently because of that. The other advantage from my perspective is that I can see the person in their home. I can see how their home is. Are there any concerns or safety concerns at home? Are there any things that we can help with the home design or with the structure of the home that can help the person stay safe and then thrive with their Parkinson's disease? But like anything, it comes with limitations. And the main limitation with telemedicine is that there is lack of human touch. Although you can see a person on video, it's not the same as being in the clinic. The other thing is that the field of view of the camera is usually quite narrow. So I can see usually mostly the torso view. So I miss a lot of information about like, what are the feet doing at that time? Is there any dyskinesia? Is there any dystonia that's happening? What about the general body posture? The technical issues are a common thing. There could be poor Wi-Fi connection. There could be difficulty connecting to the electronic system. And also the video feed quality can be poor, where there is like, when a person is trying to assess the slowness, that might not be very easy to assess. So telemedicine, although it helps a lot with some of the limitations of the usual practice, it doesn't solve all the problems. And also, for sure, it doesn't solve one of the biggest problems, but also something that we use all the time, which is all these scales that we use. So currently, whenever we track people, we use the scales, and these scales have been in development since the 1960s. They have changed a lot, and the current most commonly used scale for most clinical assessments is something we call the MDS-UPDRS, or the Movement Disorder Society Unified Parkinson's Disease Rating Scale. It's a rating scale that usually takes around 30 minutes. It's really quite comprehensive, and it covers a lot of the aspects of Parkinson's disease, both motor symptoms and non-motor symptoms and complications of treatment. It is something that most likely you've done with your doctor, whether you know the name of it as UPDRS or not, on a regular basis. And these are ways for us to track the symptoms. They are quite good, but they have also some limitations. One of them is they take time to fill. And as you can see here, there are different components to it. And then also they can miss fluctuations. You're doing that assessment only at the time of the visit, so you can see only one very narrow snapshot. And as we know, Parkinson's disease fluctuates a lot. You can have significant changes between hour to hour or even day to day. So it misses a lot of those fluctuations. And you can see one time the person at a good time with their medications and another time not as much of a good time. The scores, if we go back to that sheet here, you can see the scores are discrete. They're like from 0 to 4. And sometimes the person doesn't really fit one of those very well. And then in that case, you miss a lot of the details and then that granularity can be lost. Although we as doctors think of ourselves as like infallible and then always great, the information that we might be collecting here is based on our own opinion, and then that expert opinion is a bit subjective. So whenever we are choosing a score, for example, like let's say we're choosing mild, another doctor might choose a little bit different. And although these scales are validated to be quite good between people, there is still a little bit of difference in the scoring, and that can be biased by the patient we saw before, maybe biased by the other side, so that can affect us, and that also affect the accuracy of these scales. So one way we can supplement these scales right now is to give people Parkinson's diaries. I'm not sure if you've seen these before. These are something we can give to people. They might not be that much detail, like half-an-hour increments, but this is something you would take at home, and then you would check mark every hour or half an hour how you're feeling. Are you feeling that the medication is working? Are you feeling that it's working, but there are dyskinesias? Are you feeling off? Or are you asleep at the time? They are helpful because we can get a much longer evaluation. It is not as focused. And then it gives us also your feedback about how things are going from your own perspective. But at the same time, it's very time consuming. As you can see, that can become very tiresome very quickly. Most people would not fill it in real time. And as you know, when we're trying to remember back in memory, it's not always very easy to remember the details. So most people usually fill this by the end of the day and then try to remember early how they were doing. And then the other thing is that most people have difficulty keeping up with it. I would not keep up with it because it's like very tedious and you have to keep doing it for a few days. So as you can, this is what the state of most of the evaluations right now. And we need to have better ways of assessing people with Parkinson's, especially as we know it, because it's a fluctuating disease, it's a complex disease. So we need to have more objective, precise, and continuous measurements. And this is where the technological advancements that have happened in the last couple of decades have allowed us to incorporate technology to be capable of collecting that data that we couldn't before. The interest in collecting this data is not new. If we go back to the beginning of Parkinson's disease, whether it is with James Parkinson himself or with Charcot in the 19th century, at the time, they were already doing certain techniques to try to have a more objective way of assessing tremor in Parkinson's disease, for example. But the devices were bulky, and then it wasn't something that they could use on a regular basis. But with the significant technological advancements in the last 2 decades, and that most of the sensors and devices now are becoming very small, this allowed us to be capable of using or incorporating this technological advancement in the care for people with Parkinson's disease. And the advantages of having these more precise, objective, and continuous measures is that they would allow us to diagnose Parkinson's disease earlier by detecting milder signs that can be easily missed by physicians. And one of the issues, for example, in Parkinson's disease, that people can go a long time before they are diagnosed with Parkinson's disease, even now. So the use of these sensors can alert a healthcare professional that a person might be having signs of Parkinson's disease, so that they most probably benefit from seeing a movement disorder specialist to possibly diagnose them early. And that could be helpful for the diagnosis, clinical trial involvement, or later, hopefully, with disease-modifying treatments. The other thing is that, as many of you might have witnessed yourselves, is that Parkinson's disease has a lot of mimickers. One of them, for example, is the tremor. Is that tremor essential tremor or Parkinson's disease? Or is this Parkinson's disease or one of its what we call Parkinson plus or Parkinsonisms? So using these sensors can give us that information and help us allow us to make that distinction by looking at the characteristic features of the tremors, for example, or the characteristic features of the slowness that can help us distinguish between these different disorders. One of the most important advantages of these technologies is the long-term monitoring of treatment that will be done seamlessly without a lot of personal input. So they are going to be less intrusive than, let's say, a diary where you have to fill every half an hour or an hour. Also, it helps with better escalation or modification of therapy. For example, if you need medication adjusted because of fluctuations, sometimes these fluctuations can be easily missed, and then they might not be appropriately addressed as quickly. Or, for example, to modify therapy in terms of, for example, escalation of treatment to using deep brain stimulation. Many people might not get referred for deep brain stimulation or like the Duopa pump at an earlier time than they can be referred, because some of those fluctuations, some of those complications of treatment have not been captured quite well because of the devices that we have, which is simply a recollection and then that short period of exam. So having these continuous measures can show us that the person is having a lot of fluctuations that need to be adjusted. Also, there could be improvement in rater consistency, because as I mentioned that there is a little bit of subjectivity right now in the scales. So having something that is very objective would remove that concern. But as you can, when we're collecting all this data, you're having a lot of data collected throughout the day and for many days. What we're going to do with all that information, who's going to be sitting and sifting through all of that information to make sense of it. And if we're going to rely on human force, that's going to take a lot of time. It's not going to be possible. So this is where artificial intelligence comes in. And this is part and parcel with the developments of these sensors, is to collect the data, but then use artificial intelligence to try to make sense of it, and then present some, like a report to the healthcare provider professional to help in management. And then there are different ways right now that we can use to monitor and assess Parkinson's disease in a more objective, continuous fashion. There is videos, so you can have video monitors. And that will be similar to telemedicine, but having videos running for a period of time and then having another person then look at it. There is developments right now in having artificial intelligence automatically decode the video signal and then produce and develop certain scales or certain assessments of the patient's walking, of the patient's movements of the hands, of the patient's day-to-day activities, including how they eat. And then, so there is a lot of work being done. It's still not something that we can prescribe or something that we can use off the shelf, but there's a lot of work being done for video monitoring so that you can have a continuous assessment at certain periods of time to help assess how things are going. There are also room sensing devices. So these are devices that you can embed inside a person's room, or for example, inside the clinic room to assess how a person is doing. These will include gait mats, and we're going to discuss these in a bit more detail a little bit later. So these are mats on the floor that can assess walking, as well as motion sensors that are available inside the room that continuously detect people's movement and then can give feedback back to the physician or healthcare professional. There are also wearable devices. So these are something that a person will have to wear on them. And these can come into research settings and or clinical settings or even home monitoring. And some of these are available as consumer products. And we're going to discuss some of those, or as something that a medical grade device that can be prescribed. And there are also special situations with advanced therapy, especially deep brain stimulation with recent advances and utilization where a person deep brain stimulation device itself can be used as a sensor, and that can be directly connected to the back to the healthcare professional to provide feedback. And we're going to touch on that only very briefly. So what can we measure, or what we want to measure with these sensors and devices and everything else? So we can measure gait. As you know, in people with Parkinson's disease, gait is a major factor that can be affected. It's a major factor for safety, and then it's a major factor that affects quality of life. So some of the features that we can measure is what we call fascination. These are the small, fast steps that can cause a person to fall. We can measure hesitation, like a form of freezing. You can measure the step size, which is a good proxy of the risk of fall. We can detect falls. Many people live alone and they might fall, and then we can detect that fall and assess how they're doing. But we also can, which is even better, is to predict falls and then see if the person is at risk of falling and what can we do to decrease that risk of falling. And there is a lot of work being done in this fall prediction work right now. It's not something that is mature yet, but there's very promising work here. There's also freezing of gait assessments, as you know, that can be quite impairing. Usually for gait evaluations done at home, a person would wear 2 to 3 sensors, usually at the level of the legs or ankles, and they can be, and usually they are going to be worn for at least a few hours to do that evaluation. There is also bracelets that people can wear that help also with detecting their body movement, that can also help us assess their risk of falling and postural stability. Other things we want to measure are what we call the cardinal symptoms of Parkinson's. So these are the main symptoms, the stuff that your doctor will assess when they see you in the clinic, and that could be the slowness, the stiffness, the rigidity, as well as the tremors. And there are multiple devices that have been tested for this. And these would include, let's say, the smart watches that many of us have, smart gloves, the regular smartphone, multiple sensor systems. So these are systems that usually would be prescribed or part of a research study, and they are, we're going to see an example of one or in different parts of the body. And then also there's development of handheld devices like smart pens that you can carry. And these will like detect the stiffness as well as the tremors from time to time, and then assess the change that can happen through the day simply by using a regular pen that can be then that would transmit that information over time. Other stuff is we want to measure sleep. As we know, people with Parkinson's, their sleep can be quite disrupted, whether it is excessive sleepiness or disruption in the sleep cycle, or difficulty falling asleep, or multiple wakefulness during the night. And there are different devices that have been available on the market for a long time now, and this would be something we call actigraphy. These you can have through your regular commercially available smartwatches. Many of them come with this already built in, but also there are research grade devices that usually have multiple sensors and can detect more detailed information about the sleep. Some of those, this is going to give some names. One of them is called Axivity, and another is called Dynaport. These are certain multiple sensor devices that your doctor can prescribe to you to wear and then assess not simply sleep here, but also, but in more detail sleep. There is also a recent development. This is a paper published just August of 2022. Most of the authors on this paper are from here, from Massachusetts at MIT, and they developed a system where we have wireless signal. So if you see here at the top source here, where it says the data source, there are different ways of measuring breathing during sleep. One of them is using, that's a more traditional way, is using a breathing belt. But the technology that the researchers at MIT are developing is this wireless signal. They use radio frequency signal that can detect movement and including breathing movement. This technology has also been studied in detecting falls and detecting walking difficulties. But in this study, they used it to detect breathing. And as you can see, using this wireless signal, which is completely not intrusive, you don't have to have a belt on your body, the researchers were capable of detecting the exhale and the inhale, so allowing them to determine the breathing pattern, which in Parkinson's disease is affected because of the changes of the sleep cycle. And then using that information through this artificial intelligence, again, going back to that artificial intelligence, to make sense of this data. And they use this information, and that allowed them to be capable of distinguishing between people with Parkinson's disease and people who did not have Parkinson's disease with a good detection accuracy. And then also people who already have Parkinson's disease estimate if their disease is progressing, because as the disease progresses, the sleep pattern gets, or the breathing pattern during sleep gets disrupted even further. And that correlates with their scores that their doctor measures in the clinic. So as you can see, this is very, very interesting work, very not intrusive work. You have simply a sensor attached to your room, and then that can either help diagnose or like assess if the person possibly can have Parkinson's or raise the alarms, or assess if the person's symptoms are progressing without doing anything that the person has to wear on them, or blood tests or anything invasive. So as you see, there's a lot of these exciting developments happening to help assess these symptoms. Other things we want to assess are gastrointestinal symptoms. So that would be constipation, swallowing problems, problems with the bacteria in the intestines. As you know, there's a lot of great interest in assessing this brain-gut axis, the change on the bacteria in the intestines that can have a big impact on disease development as well as disease progression and symptom evolution. So some of the stuff that are already studied is something called the plate to mouth. This is a way of assessing how much it takes time to bring the food from the plate to the mouth. That's a good proxy for other motor symptoms, mainly the slowness. Also, we can use the wearable sensors to help us assess how different gastrointestinal symptoms relate with motor symptoms. So, for example, in a study using the Fitbit, researchers were capable of determining that when a person is constipated, they're going to have worsening walking, they have less steps, their sleep is disrupted, and they have much more inactivity. And then there's also smart toilets. You already can start buying some smart toilets, but they are not very smart right now. But there's a lot of research to make them smarter, where after you have a bowel movement, for example, the stools will go in and will be analyzed. And they will be analyzed for different factors that can help us determine gut health, that can help us determine evolution of Parkinson's disease. This is still in infancy. It's not something that you can buy. This is very early research, but that might be available in the next few years, where you can have a smart toilet that can track your Parkinson's symptoms simply by analyzing urine and stool. So these are certain changes that might be happening in the next maybe decade or so. Other things that we can measure or we want to measure are mood symptoms, and then as well as cognitive symptoms. These usually, these higher level mood and cognitive symptoms usually require multiple sensor modalities. So people usually use those sensors that allow detection of motion, detection of heart rate, sleep hours, temperature, light exposure, amount of steps. They also incorporate how many times people engage with their phones, how many times they engage with their apps, to approximate their mood as well as approximate their cognition. And there are also a lot of work here combining these sensors with virtual reality, which we will discuss later, in order to better assess cognition by using these types of tests that can help a person assess if their cognitive skills and mood symptoms are changing over time. So many of you might start seeing, might already be seeing this or will be seeing this commonly in most of the clinics where you will go in. And then before you would see the physician or the physician extender, you will be asked to walk on a sensor device or use a sensor device. So one of these are these gait devices, these mats that are on the floor. So many clinics have these already established. And when you go in and then walk on the mat and then get a collection of the data. There are certain devices here that are already available, like Gait-Rite, Strideway, Zeno Walkway. And these are usually available inside the clinics. So you go in, walk through that mat, usually back and forth. And then your doctor will get such a report. You can also get a report like that yourself, depending on the clinic. And then it can tell you how your steps are happening, what's the distance between the steps, what's the distance horizontally and vertically, let's say, between the steps, how long you stay on both feet. And then these are all good markers to help assess your risk of falling, and you can track these changes over time, see if your step length is getting shorter, which could be an indication that your gait is getting more affected. And then this is usually the report that the machine will get out, and then it gives you for each one of these components what is the normal, and then if you fall outside the normal, and then you can track these from visit to visit. Again, these are not something that will replace the clinical assessment, but will give you a good estimation of how things are changing, and then also help you and your doctor pay attention to changes. So if we notice that your step length is decreasing, maybe we need to work more with physical therapy, maybe we need to adjust the medicines, we need to see what's going on to help decrease, because that can increase your risk of falling if that continues to worsen. In addition to these gait or mat gaits assessment techniques, you can also have multi-sensor tracking systems. These are a couple of sensor systems I'm mentioning here, the F-scan, that's mainly present in China, and then the Opal system. And then you can see here, there are multiple sensors that the person is wearing, some on the chest, some on the hands, some on the legs. And these systems can also be used in clinical space as well as research space for sure, to assess the person's posture, assess their balance, assess their hand movements, their leg movements, and gives us a lot of information about how they're walking as well as their posture is evolving over time. And as you can see, these can be a little bit cumbersome to wear at home, but there are certain devices that your doctor can prescribe for you to use at home to assess your symptoms over time. And the two that are already FDA approved in the United States are the Kinesia systems and the PKG systems. And then which one your doctor would offer depends on the doctor's clinic and which one they work with. I work mainly with PKG, but both of these are very, very similar. They help you assess tremor. help assess slowness or bradykinesia, dyskinesia, as well as assessing mobility or immobility, which is an approximate sign for multiple features. This is the Kinesia 360 device. There is one sensor for the foot and one sensor or the ankle and one sensor for the hand. And then the PKG device comes only with a wrist sensor. So the Kinesia device gives you a little bit more information about the leg and the movements of the foot itself, whereas this one approximates it a little bit less accurately. And the studies have shown that these types of devices are better than healthcare providers in assessing people's slowness and bradykinesia. So they are currently, for me, are very important for many patients. We usually prescribe these. Patients will wear them for 6 days, 7 days, and then I'll get a report. I'm going to show you how a report comes up. So this is the PKG system. As I said, they are very similar. So a person wearing this watch device, as you see, it has a face. Whenever they take their medicine, usually we program when they need to be taking their medicine, the device will buzz. When they take their medicine, they swipe that device, and then we get these red diamond-shaped structures over here. And you can see that sometimes, as we'd expect, that the medicine are not exactly taken on time. But the other thing that it will detect at the same time are these lines. These lines detect, on the green line detects the dyskinesia, and then the blue line detects the bradykinesia or the slowness. And here on the dyskinesia, which is like the uncontrolled movements, you can see that this person is not doing very well. They're fluctuating. There's a lot of dyskinesia going up and down throughout the day. And then the bradykinesia is high. This is gives you an information about how bad is the bradykinesia for that individual. So that gives us an idea about how they're doing without them needing to do anything except swiping the face of the device every time they take the medicine. And then the device does it continuously. They can wear it throughout the day, throughout the night. It is water resistant, so they can shower with it. So they only need to wear it for 6 days and then ship it back for analysis. And that's the only thing with the device. And then it can be helpful. For example, we can see here that we discovered that this person is having a lot of problems with dyskinesia. This person elected to do it, the levodopa intestinal gel, and you can see that the dyskinesias in green have significantly decreased after the treatment. So these types of devices can help you detect changes that might sometimes be missed in clinical interviews. The other thing is that, as I mentioned, the consumer devices. So these are your Apple Watch, your Samsung Galaxy smartwatch, your Fitbit, your Garmin VivoSmart, many others of these devices that many of us have, one or two or more of them. They can help for many ways. First of all, they all have apps that can be used to replace the diary. So rather than filling paper forms, you can get apps, and they're much easier to fill if you want to use that. But in addition to this, they have their own automatic detectors to detect sleep, to detect your heart rate changes, which can be very helpful with autonomic changes in Parkinson's disease. They can detect temperature changes. They can also detect they help with fall detection. And all of these right now have that fall detection feature, the newer versions. But also the newer developments for these consumer devices will be embedded sensors. So these are sensors inside stuff that you use every day, like inside fabric. As we saw also in the MIT researchers developing these radio signals that you can have as a device at home that without having anything on you, and then also shoe sensors that can continuously monitor your walking. This is one of these fabric sensors developed here at in Massachusetts at the Harvard Innovation Labs called MyoExo. These are small sensors that can be embedded inside clothing. The clothing has to be tight fitting, but that most likely will change over time. And they can detect a lot of the changes that are happening in the muscles that will help us determine the movements of the body, the contraction of the muscles, see if there's any slowness, any stiffness, any tremors. And these can be incorporated inside clothing. This is prototype, so it doesn't look nice, but as technology develops, this most likely at some point will develop into a clothing thing that a person can wear and can help us detect these symptoms quite well. And another development that's still in its infancy is something called biochemical detection. As you know, in Parkinson's disease, there's a lot of biochemical changes that happen. There is abnormal alpha-synuclein, there is a decrease in levodopa, there is multiple other changes. And then some of these changes we can detect on in the blood or the tissues outside of the brain. And there is work on developing these chips that can be inserted in the skin with small microneedles, so it shouldn't be painful. It's just like you put on the skin, similar to many of the sensors that we have right now for people for monitoring diabetes in many individuals, and they will detect the changes in the different biomarkers. At this point, though, we don't have very good biomarkers that are developed. The only one that has made some stride is detecting levodopa in the fluids and to assess how is that fluctuating. It's not clear if the fluctuation of levodopa in the fluid on the outside of like not inside the brain correlates quite well with inside the brain. So there's more work needs to be done. But there is some evidence that we can detect this levodopa level quite well, either with these microneedles or even from the sweat of the skin. Currently, there are no detectors for alpha-synuclein, but there's a lot of work being done on having these small sensors that can be just slapped on the skin and then can give us continuous information about how the levodopa levels are changing, how other factors with Parkinson's disease are changing. Again, this is still in infancy. A lot of work needs to be done before this can become used for even clinical trials. All right, so these are a quick whirlwind about the world of sensors, whether they are wearable sensors or non-intrusive sensors like this radio frequency sensor, or like sensors inside the room type of devices like the mats. I'm just going to switch gears right now to speak about virtual reality. Many of you might have tried virtual reality either at home or even in a clinical trial. So virtual reality is, by definition, something we call a human-computer interface based on perception. The most common perception that we're using there is visual. As you know, it's a device where you would wear over your eyes, and then we'll create this virtual environment. But virtual reality is not simply is not simply visual. Many of the virtual reality applications also have tactile feedback. So as you are interacting with that virtual environment, there is some tactile component that comes back. Most of them usually right now are in form of vibration, but developments are happening to work in terms more of also pressure sensation, heat sensation, and other features of temperature, and also kinesthetic, which means like the movement itself, like how things feel in movement, or the proprioceptive feel. So this is a field that's growing also in interaction with many neurologic conditions, including in Parkinson's disease. The advantage of virtual reality devices is that they allow you to have the same activity in a very repeated fashion. And repetition is very important for neuroplasticity. And there's a lot of work being done in virtual reality that shows that if you repeat this different activity multiple times, that helps improve neuroplasticity, which is very important in conditions like Parkinson's, which we call them neurodegenerative, where your brain loses that plasticity. So having these repetitive activities that can be done very easily in a virtual reality environment, because simply it's a device, that helps with that neuroplasticity and help improve people's outcomes, or at least that's the hope. Also, it gives positive feedback. As you know, in people with Parkinson's, there is decrease in attention, executive function, which is this higher level functioning and paying attention to detail, can become decreased. And then visual spatial functions are declined. Virtual reality is really good at harnessing these functions quite well and combining them together and pulling the person's attention to them. So that positive feedback that the virtual reality system can develop or can have is very helpful, and then can be significantly a significant addition to the treatment plan for people with Parkinson's disease. Also, you can do different types of assessments and training in environments that cannot be done in real life. A person might be at very high risk of falling, and you cannot assess their balance or train their balance very safely without like a lot of devices. So using the virtual reality environment, you can do it in a safer way by creating this virtual environment that cannot exist in real life and assessing gait in that way. Also, it can improve the understanding that will be more from a research perspective of how gait and balance works in humans so that we can understand it better and then have better treatments for it. And then also it improves access to rehab services, especially during the pandemic. Many people could not go and then access rehab services. Many of that developed into telerehab, where you get the physical therapist or occupational therapist on doing like a similar to this, a Zoom discussion. But the virtual reality can complement that, and there are multiple companies right now that offer this combined virtual reality and tele-rehab at the same time, and they complement each other, where you can have the virtual reality type of exercises and training, and in addition to this, also the tele-rehab person there coaching and then helping with posture, with exercise at the same time. And the research has shown that combining these two together is better than doing one at a time. And then also, as with any type of thing we want, like let's say physical therapy, medication use, training, cognitive training, it can be boring sometimes. So, and then it might be difficult to keep up with doing these activities. So virtual reality has this game feature to it. It is much more engaging. So it increases the incentive to continue using the services and help people stay on track with their treatment plans. Now, as I said, there is suggestion that there is a good, that virtual reality, especially when combined with telerehab, is very, very helpful for people with Parkinson's disease. But at this point, the quality of the data remains poor. There's a lot of variation, like each study is done very differently, what they assess is different. So it's very hard to compare them and combine them together and then have more information by doing that. So at this point, the information I'm giving you here is still preliminary information, but there seems to be evidence that combining virtual reality with telerehab is better than regular physical therapy in improving gait speed, in improving stride length, in improving balance, in improving activities of daily living, and postural control, which is like how easy it is a person to lose balance and fall down. And the idea why this could be the case is going back to this positive feedback, where this attention, executive function, visual spatial function are affected in Parkinson's disease, but virtual reality is by its nature very engaging for those centers and allow these centers to engage better than a regular physical therapist will be capable of doing on their own. But this needs to be taken with a grain of salt at this point because the data, as I said, quality of the data is poor, but that is hopefully something that can be supplemented with regular PT regimen having a VR component to it. Now, there are two ways of doing virtual reality. There are commercially available systems that you might have used before, and these can be easily accessible. You can buy them yourselves, and then many people are familiar with using them in their day-to-day life anyways. But there is some concern that they are not adjustable, and they might not give as much benefit for people as the individualized systems that are currently mainly research grade systems. But at this point, they are not easily accessible compared to the commercially available systems. So there are both pluses and minuses for these, and more research will help us clarify this further. And then in one of the studies, they tried to determine to see what is the optimal virtual reality regimen. And this is some of the information that they came up with, is that the sessions usually should not be more than 20 minutes. So from 1 minute to 20 minutes. More than 30 sessions of training seems to be better than less number of sessions of training. Training 4 to 6 times a week seems to be better than training less. Training 200 to 300 minutes a week, which is quite a lot, because currently our recommendation for physical therapy is 150 minutes or more a week. So that's quite a lot of virtual reality training. And then also a duration of 3 to 5 weeks of training seem to be quite well to give you the benefits that you need. So these are some of the current initial information about how to use virtual reality regimens when you're applying or using those services. As I said, many of them are available right now, and then you can access them clinically. And there is some evidence that some individuals might benefit from virtual reality supplemented telerehab better than other individuals, and seems to be individuals who already have balance problems may improve better. So that will be a scale, so something called the Han and Yar scale, that's usually more than 2, that tells us that the person has difficulty with balance, which means when you go to the doctor and they pull you and you have difficulty stopping yourself, that usually, it seems, it's not very clear yet, but it seems that these individuals might benefit more from the virtual reality supplemented rehab than the regular PT. Now, one thing that's important to keep in mind when considering any of those devices, whether virtual reality devices or sensor devices, is to keep in mind that these components, many research unfortunately does not take these components into consideration until later, and then the devices don't work well. So comfort of use, how hard it is to set up the process, the instructions, are they too complicated that you need a PhD to do? Is there any support, technical support? Are they aesthetically pleasing or not very nice? And then also the display features, are they easy to read? Are they bright enough? What's the contrast? So these are also very important for researchers when developing these technologies. And many technologies that are developed, unfortunately, do not take this into consideration and then end up failing. So this is one way to think about managing Parkinson's disease that many of us are already doing in our clinics, is to incorporate these sensors that will collect the information. These sensors here, they are manifested as wearable sensors, but as we saw, there are multiple forms of sensors that we can use. And then get that information. The information is then analyzed with the help of artificial intelligence. Then we get a report, usually preferably before the next visit. We compare this report, then do our discussion, do the usual clinical assessments, usually fill the questionnaires, do the clinical assessment, and then take all that information together to adjust the treatments, to recommend changes, to predict complications in the future and try to address them proactively, and then the cycle would continue. Virtual reality can apply here in one of the treatments as well as the assessments for both motor and cognitive features at the same time. So this is what I have for today in terms of the discussion. As I said, I'll be happy to take questions, discuss what you think about this, what your experience has been. And these are the, I'm going to show you the references. If you are interested in reading, many of these articles, unfortunately, are behind the paywall, but to access, but some of them are open access if at some point you are interested in reading them. In addition to this, I'm just going to do a personal plug about a program that we're doing here at UMass in collaboration with the New England Botanic Garden at Tower Hill in Boylston, Massachusetts. It is a pilot program for Parkinson's disease and horticulture. Many individuals with Parkinson's or without Parkinson's love to garden, but then Parkinson's disease can make gardening a little bit tough or make it a bit dangerous because of balance problems. So we're going to do a session where we can discuss how we can combine it, the advantage of horticulture and gardening for Parkinson's disease, and then also how to continue doing it safely with Parkinson's disease. The first session is this Saturday, 9/24, from 10:30 to 12. You can scan here if you want to register. It has limited number of tickets because it's a pilot program initially. And then hopefully you'd consider that something that you might be interested in joining. And that's it. I'll be happy to take any questions, and thank you for listening to me for such a long time. Okay, I have, I'm going to stop sharing my screen. So, okay, I have one question here in the Q&A. Why do you think my neurologist hasn't had me use a sensor system to track the effectiveness of my medications over time to monitor how a change affects my symptoms instead of relying on patient reporting? There could be, I cannot answer why that question, but there could be many reasons. One of them could be either they're not familiar with the technology, or it could be that they're not sure about the level of evidence, because it's not 100%. It's a complement. It doesn't replace the doctor's assessment. The other thing also, it could be not being aware of how to get it, because it is you have to like partner with the company, and then you get some training. So it is something that not every clinic is doing at this point, but you're going to see that becoming much more frequent. What I would recommend is that if you're interested in this, ask your doctor about it, and then they can check it, and then maybe you can pioneer that in the clinic that you're seeing. It does pay, the DO devices, PKG and kinesia, are both covered by insurance. Could I have a copy? I think the thing is going to be recorded, is recorded, so hopefully you can access that way.
Yeah, we can send around a link once it's uploaded to the YouTube channel to anybody who's attended. Yeah, thank you so much, Dr. Deeb. While we're waiting for more questions to come in, I was actually wondering for myself, do you envision that these wearable sensors or virtual reality would replace a number of in-person appointments over time? Do you think there's still the need to see all the subspecialties at least once a year, or do you think it would be less frequent when you combine these other methods?
Yeah, I think not now with the level of the maturity of the technology, but later as the technology matures and becomes better, I think it will replace some of the visits. It will allow us to, it will be almost like I get a report, and then from the report, I can immediately send some recommendations and then limit the times that I would need to see the person in person. Now, is that good or bad? We'll see. But I think as the technology is developing, and especially with these non-motor, I'm very excited about the non-motor sensors, like doing the continuous measurements of the sweat signals, of the stool signals, of the urine signals. These can, most likely, once they become mature technologies that we can use, are going to significantly change the way we practice medicine. Can you please tell us more about non-oral delivery of levodopa? Yes, I can, a little bit. The non-oral delivery of levodopa, currently there is the one that's available is the levodopa intestinal gel that you can get. It's FDA approved and you can get. And then, as you all know, there is also the subcutaneous devices that are currently in clinical trials that should be approved soon, hopefully. These are the two ways of the non-oral delivery that are most promising or currently in use. There is work in being done in trying to see if we can have a continuously cutaneous delivery of levodopa, but that's not available at this point, or not close to maturity at this point. I'm not sure if I answered your question, but hopefully I did. How would we pursue using VR for our PT? So there are companies right now that are available. Some of them are here in Massachusetts, available for you to get virtual reality and PT. So they have PT and OT and speech, and they stay at their like workplace, and then they ship you a virtual reality device that you would wear, and then you would do a televisit like usual, but with your rehab person, and then that rehab person will develop a series of exercises with you, a series of that combine both virtual reality and direct exercises, and then you do regular PTs that way, but combining it with VR. So it's already something that you can be prescribed. It is a regular referral to PT, but it will be to these companies. Are there systems to monitor non-motor symptoms? At this point, the only ones that we have that works well is sleep. we have good ways of monitoring those, like to assess like how restless your night is, how many times you wake up in the middle of the night. These are the ones that are most efficient right now, or most mature right now to monitor non-motor symptoms. The other ones like mood, cognition, let's say hallucinations, or if we're discussing, let's say, low blood pressure, they are not as well developed, and not some of them are a bit intrusive. So you can, for example, do a blood pressure monitor. These are something that are available that you can wear for a few days. But they are not the most pleasant looking aesthetically type of devices. But there are many of the smartwatches right now are developing blood pressure monitors. They're still not very good, but as they mature and we can test them in Parkinson's, they will become something that we can use for some of the non-motor symptoms. But that's a field that's growing, and that will be very helpful, especially because non-motor symptoms, unfortunately, sometimes are not discussed in the clinic visit, because we have that half an hour or 20 minutes with the patient, and then you're discussing dyskinesia, you're discussing falls, and then you maybe discuss maybe swallowing problems, and that's it. And then, but there's so many other things going on that hopefully having those devices as the technology develops will be helpful. Like my watch, yeah, so in your watch, I'm not sure which watch you have, but they're all very similar. The smartwatches, many of them, especially the newer generation, so you'll have to get the more expensive one. So newer generation smartwatches for all the companies, especially the bigger ones, have capacity to detect your heart rate quite well. They can detect your sleep quite well. And some of them can detect your blood pressure. Not greatly, but can detect your blood pressure to a certain extent. So these are certain ways. Now, there are some apps that you can get on those watches that can also help you track your symptoms yourself. So, and make it easier to track. So rather than doing check boxes and filling paper forms or going to like a special app that you have to, that's very complicated, there are some easy diary apps that you can use to download. There is also, if I didn't mention that very much, but if a person has DBS, there are different interfaces that can allow you and your doctor to get more information, whether from the DBS device itself or from applications and apps that can be used on your phone or on your smartwatch that can track your symptoms and then combine it at the same time to the DBS signal. So people with DBS get like that extra layer because there's already a device inside that we can use. But this space is always going to grow. It's going to change very quickly. The big companies, let's say we're speaking here, Facebook, Apple, Samsung, they're all very much invested in tracking health, and Parkinson's disease is on their radar. So we're going to see a lot of changes in these devices. Yeah, so the apps that measure bradykinesia available on the market right now are not great. So let's say your Apple Watch can measure bradykinesia, but and there are apps like that right now that are advertised for this, that can measure tremor, can measure bradykinesia. I use some of the apps to measure tremor in the clinic. I have apps on my phone. I stick it to the patient's leg and then measure the tremor that way. Many of these are not validated for bradykinesia for Parkinson's disease. Tremor is a bit easier, but for bradykinesia and rigidity, it's a bit trickier. So I usually defer to the FDA-approved FDA-approved devices like the kinesia devices or the PKG devices for this.
Great. So I don't see any more questions coming in right now. We definitely have a little bit more time if anybody has any other last minute questions. But thank you so much again, Dr. Deeb. This was such an informative talk and you covered a lot of different areas. So we'll be excited to share everything on YouTube so people can go back and review certain sections. I know I learned a lot working on clinical trials. We're still on all of the paper scales, so it's exciting to see things starting to move forward to wearable sensors and more advanced technologies.
Yeah, thank you again for having me. As I said, it's something I like. I like to make everybody bionic. And they have their own pluses and minuses for sure. There, we have to keep in mind privacy, and we have to keep in mind how much they're intruding in our life that we don't want, and how much information they're collecting about us. And this has to be like baked into the research protocols as they're being developed and used. But I think they still offer a lot of good stuff that I think we shouldn't shy away from. There's a question here, can I purchase one of these devices, like a PKG device, and monitor myself? Now, the PKG device you cannot purchase yourself, but there are other devices on the market that you can purchase yourself. There are multiple devices. There are different indications the FDA gives. There is something called FDA cleared devices, which means that they are cleared for safety, which means that they are device that the FDA tells you that this device is not going to burn you or electrocute you or kill you, and you can buy them. It doesn't say anything though about their clinical validity. Now, then you can discuss it with your doctor to see if they think that device has some information or some data. There are, like, for example, in the field of tremor, a lot of great devices, and some of them have some claim. Like, for example, there's something called Steady 2 device. It's a device, it's like a glove that you can wear on the hand. It works for some people quite well for essential tremor, and for very few people with Parkinson's tremor. But it is a device you can go and buy. It will cost you, like, I think $650. I don't remember exactly the price, but it's not covered by insurance, and that's something you can buy on your own and then assess. But there are not a lot of, so these are some of these devices. As I said, for bradykinesia and rigidity, the algorithms needed to detect it very well and not being fooled by other things you're doing in your day. So for example, if you're exercising, a device that has not a very well developed algorithm might miss the bradykinesia, or might think of it as something else. So I would, for those, I would shy away from these devices, and then ask your doctor to ask for, like, the medical devices for that component. But you can explore that space. There's a lot of stuff. Check it with your doctor, read about it, see if you're interested. Many of these come with, like, a money back guarantee. So you can take them, buy them, see if you like them. If you don't like them, you can send them back.